I think, which is obviously paramount, is doing the best you can for the patient and making sure that you do complete and comprehensive sinus surgery. A couple of disclosures. So preparation is key, and I kind of look at there's a lot of truths to anatomy, and that's because we're all kind of come from the same kind of four cells that then develop in the exact same way. And utilizing that truth in embryology allows us to do sinus surgery in a very kind of stereotypical and regimented pattern that I think allows for safe, effective, and comprehensive surgery. So when you're looking at anatomic variations in the sinus, I think it's important to realize that those anatomic variations are just slight deviations from basic ground truths. So I think as has been mentioned, the lowest point of the skull base is at the sphenoid, and everything comes out and forward from there. So once you reach there, you've kind of hit the base, and you should not go and you shouldn't go higher there. The narrowest point of the sinus cavity is at the orbital apex. Again, kind of like a funnel, everything comes out towards you. The frontal outflow tract is always going to be medial, unless it isn't. But even in that case, it is, and I'll go over that again a little bit later. I know a couple residents in the back are rolling their eyes about that. The sphenoid os is always going to be medial to the superior turbinate, which we discussed yesterday, and then the ethmoid cavity always pneumatizes, and everything does pneumatize off the lamina. And that again, that understanding that with growth and development of the sinuses, everything is coming from lateral to medial, tells you where those bony connections are. That allows for effective, safe, and efficient removal of those partitions to allow for comprehensive and really nice surgery. So there's a couple of different preoperative checklists. I think the one that most people are really familiar with is this close mnemonic. I think the close mnemonic is great. I think the way I always kind of look at it, and maybe that's just the way that things were kind of hammered into me during training, was that was kind of an avoidance mnemonic. It was kind of like, hey, watch out for this. Don't get into trouble this way. And I think again, if you go to that basis of the sinuses are all really kind of preserved in everybody, you don't have to be so scared of things. Instead, you can look at how can you prepare to do full sinus surgery and make sure that you're understanding the anatomy of the specific patient so that you can get comprehensive surgery done. So I use this review of anatomic variation, which unfortunately doesn't have a nice mnemonic to it to look at, but we'll go through each of these. So I won't belabor it at the moment, but I think each of these is really important in preparation and allowing you to safely and efficiently move through your surgery. So the first is this height and slope of the skull base, asymmetry of the skull base, and you'll see in these slides from the left side of the screen, you've got a much more optimal orientation or anatomic variation, and then as you move over, you have this less optimal or kind of more something to be more aware of. You see here on the left side, you've got a nice kind of corner, right angle slope to the skull base. I don't know if you can see you can't see my mouse. Okay, and it's pretty symmetric bilaterally. The skull base takes a nice gentle slope here, and this is kind of one of those cases where that as long as you get all those cells off the lamina, you're going to have a nice wide ethmoid cavity. As you move to the middle here, you see you have this more obliquely oriented skull base here, and that is, one of those things where you need to be prepared that when you do take those cells off laterally and you try to go medially, that you could run into the skull base. So just being aware of that. And then I think, as Nathan mentioned yesterday, that having that that obliquely oriented skull base on the right side is where classically we believe that there is more likelihood of skull base injury and CSF leak. So when you have that nice right angle on the left, and you might be like, oh, this is great, skull base is high, I've got all these cells, and then you move to the right, and all of a sudden your muscle memory could put you right into the skull base. So just being aware of that is really important. But I would say that's a less optimal orientation. The position of the anterior ethmoid artery, which we know I won't belabor, it can either be in a up high in the skull base with a nice bony covering, which you should still be able to see after a complete dissection, or it can be in a thin mesentery or mesentery down into the ethmoid skull base. And just being aware, understanding that the visual kind of signs of that when you're in the sinuses, it has a very classic appearance, this kind of the way that it traverses along the skull base. It should be one of those orientations that you see up there, often with an angled scope, where you just know you're not going to take a kerosene or a through cut to that kind of shape. But if you're aware of that, that's going to help you as well. As Stacy talked about yesterday, understanding, being prepared for the shape, integrity of the lamina. Many patients, they might have, I was hit with a baseball when I was 12, or, oftentimes people have told them that they have this as opposed to them knowing that they had this. So being aware, knowing that, it does make for challenging dissection. This CT, fortunately, there's not a lot of inflammation kind of around that, but certainly if there is, that can be something that clearing out that inflammation can be quite challenging. And so being aware of that and knowing that you can't take a bite through that is important. There is, the way, at least in my technique for doing sinus surgery, there's only a single blind move in sinus surgery, and that's when you traverse the basal lamella, going from the anterior to posterior ethmoids. And so for that, you want to go low, you want to stay low, as was talked about yesterday. But if there is a really low posterior ethmoid skull base, and you aren't at that kind of low point on the middle turbinate, you do run the risk of entering the skull base in that posterior ethmoid area, which is the most common place for skull base injury. So I will look at, when I'm looking at the CT scan, I'll compare the relative height of the posterior ethmoids to the maxillary. And you're looking for a 2/3, 1/3 as kind of an optimal ratio for that. And so you'll see, this is kind of like, maybe even more than that, maybe even like a 3 to 1. And then as you move forward, that changes pretty dramatically. And so, again, the image on the right is a less optimal and one that you want to be much more aware of when you are making that, that move through the basal lamella with whatever instrument you choose to do, but making sure you stay low on that middle turbinate in all cases, but especially in those ones. This one, I think, is important both for preservation of the orbit, but also understanding how you're going to progress through the case. Understanding the position of the uncinate. The uncinate is, I think, a very important structure to remove in chronic sinusitis to allow for appropriate aeration and delivery of topical medications, as well as functioning of the maxillary sinus postoperatively. And so, being aware of how that's sitting, how it's sitting in comparison to other named cells, as in this case, a Haller cell over here, or in this case, kind of this atelectatic, or moving towards an atelectatic sinus here, where it's going to be plastered right on the orbit, and understanding how you're going to get that, and anticipating what instruments you might need in order to fully remove that uncinate and allow for movement to the next stage. And then presence of named cells, those are important for being kind of, again, preparing for the surgery, making sure that you're fully through. A Haller cell especially, you want to make sure you're not leaving, either you're not opening that and thinking that that's the natural os, you're removing that to allow for that. When it comes to Anodi cells, you don't want to mistake those for the sphenoid, that's for a patient care standpoint, but you also don't want to be, thinking there's additional septations up there, as is in this case, with a pneumatized clinoid there. So you want to know that where the optic nerve sits in relation to those cells, but again, being able to fully open the cells and making sure you're doing the best for your patients. And then so back to the frontal sinus anatomy, this is an endoscopic view here, a little schematic with an angled scope. So you have your agranasi and your ethmoid bulla and your middle turbinate, your orbit. And, in most patients, your frontal sinus anatomy is going to sit kind of medial here. And again, that's because these cells are all coming off of the lamina. And so they're pushing that frontal outflow tract medially. And in the one situation where that may not be the case as much is in the situation of an intersinus septal cell, or intersinus cell, and even in that situation, you're not going to find the frontal outflow tract here against the orbit. Again, it's still going to be kind of in this medial orientation, but it's just going to be pushed a little bit more lateral. So, preparing for that, looking at multiplanar view on your CT scan to anticipate what your frontal sinus anatomy looks like, the presence of other named cells, whatever naming convention you use is important to make sure that you're prepared to fully open the sinus and you're not getting fooled just getting into a supraauger cell or only into an intersinus cell. I'm moving for any questions.